Ventilator modes. Ventilator modes are one of the most confusing part of trying to learn about mechanical ventilation. It shouldn't be that difficult. We're simply talking about the type of breath being delivered from the ventilator, whether the ventilator is targeting pressure or it's targeting volume, and whether it's spontaneous breathing, the patient breathing, versus the machine breathing, which we call mandatory breathing. So there's spontaneous breathing, mandatory breathing, and we're targeting pressure or we're targeting volume. So it shouldn't be all that difficult. And when I went to school many years ago, uh, our ventilators weren't very sophisticated yet. They hadn't been doing mechanical ventilation that long. We had our ventilators, we had 3 modes that we had to learn as respiratory therapy students. Control meant that the ventilator controlled everything. The ventilator would deliver a breath to the patient, and we would set a respiratory rate, so the ventilator would deliver that breath every few seconds, depending on the rate we set. And if the patient wanted to breathe more than that, say for instance, if we set the ventilator to give 12 breaths per minute, but this patient wanted to breathe more than 12 breaths per minute, he wouldn't be able to. The machine just ignored his inspiratory efforts and just gave him the breaths that were prescribed and no more. And that was kind of tough on a lot of patients. Somebody came along, an engineer, that figured out a way to make the ventilator be able to sense when the patient was trying to take a breath. And we call that sensitivity. Originally, the sensitivity was set as a amount of pressure, a small amount, 1 or 2 centimeters of water pressure. The patient will make an inspiratory effort, and since his ET tube is connected to the ventilator tubing, and that's a closed circuit, when he made an inspiratory effort, the pressure would drop in the circuit, and that's what the machine would sense to give him the breath when he wanted it, not necessarily because of the timing of that would set by the respiratory rate. And so we called those breaths assisted breaths. So the patient may have a rate of 12 set on his ventilator, but if he wanted to breathe 18 or 20, he could. But every time he made an inspiratory effort and triggered the ventilator, he got one of those mandatory breaths. And those breaths would either be pressure targeted or volume targeted. And that we didn't really need to use control anymore. Sadly, some people would still use control for usually the wrong reason, and it was just not a very useful thing for patients. After a while, though, somebody else figured out a way that we could let the patient breathe spontaneously, so that when he made an inspiratory effort after his machine breath, before the next machine breath would come, make an inspiratory effort and just take his own spontaneous breath, not a breath forced on him, a mandatory breath, just spontaneous. And they call that IMV, intermittent mandatory ventilation. So the patient would be breathing spontaneously, and intermittently the machine would give him a breath. So that was about it with modes of ventilation way back then. And then every now and then somebody would invent something new for the ventilator to do, and engineers designing the technology to achieve those things. But then along came microprocessors. And when microprocessors started to control the ventilators, the engineers could make that ventilator do anything. Anything that a respiratory therapist or a doctor would dream up or think would be a good way to ventilate a patient, because of the microprocessor, the engineers could make the machine do that, whatever it was. And so that's where the confusion started. When they started coming up with new ways to ventilate the patient, they would often call that a new mode or breath types, or just a new type of ventilator. So that led to a lot of confusion when you had all of this. You had assist control, AC, CMV, IMV, SIMV, volume control, pressure control, PRVC, volume control plus, pressure support ventilation, volume support, AVAP, CPAP, IPAP, EPAP, BiPAP, dual PAP, APRV, bilevel, bivent, MMV, HFOV, ATC, and a lot more. So now you can kind of see where people get kind of confused and aren't understanding modes of ventilation very well, because these ventilator manufacturers would start to call these things a new mode of ventilation, when it really wasn't a new mode. It was just a different acronym. Now, a lot of these things was very helpful to patients, and this was a great technology and made our ventilators so much more patient friendly. But they confused everybody by calling everything a different mode. Assist control and CMV is the same thing. There's no difference at all between assist control and CMV. The IMV became SIMV because the patient was breathing in IMV. He wasn't really synchronous with the ventilator. In other words, the ventilator would give the patient a breath, and then he would take a spontaneous breath and exhale, take a spontaneous breath. But if it was time for the machine to give another breath, it would force that breath on that patient while he's trying to exhale. So the patient and the ventilator weren't very synchronous, and so they just invented SIMV, and the S stands for synchronous. And with SIMV, the patient would not have breaths delivered to him while he's trying to exhale. The machine would wait until the patient made an inspiratory effort and then give him an assisted breath. Volume control is the way the breath that we're delivering. We're targeting volume or we're targeting pressure. But some ventilator manufacturers will say volume control is their mode and pressure control is a different mode. And those are actually not modes, those are breath types. The mode would be assist control, and the breath type would be volume control or pressure control. And then they came up with other kind of acronyms for other kinds of ventilation, as you can see here. Anyway, you can see that it can get very confusing to people who are trying to learn about mechanical ventilation when all these acronyms are thrown at them. So I'm going to try to make this a little simpler for you. As beginners, you got to have a simpler way to understand this, and that is what you see here. This chart here shows that there are three modes of ventilation. There is CMV, which stands for continuously mandatory ventilation, and another name for that is assist control, or AC. They mean exactly the same thing. And in a CMV mode, continuously mandatory, all the breaths are mandatory. So you preset a breath on the ventilator, either volume or pressure, and a respiratory rate. So the patient's going to get those breaths at the frequency that you set on the ventilator, the breath rate. If the patient wants more breaths than that, he can easily, just by making an inspiratory effort, and trigger a breath. So you would have controlled breaths and assisted breaths. So they call that assist control. Go over here to CSV. That stands for continuously spontaneous ventilation. You know, we can intubate our patient, connect him to the ventilator, and set no respiratory rate on the ventilator, set no tidal volume, no pressure. Just let the patient breathe spontaneously. So what is the mode of breathing? The mode of breathing is spontaneous. So we have modes of spontaneous ventilation where if we put the patient in a spontaneous breathing mode, the machine's not going to do anything. He's going to have to initiate all of his breaths. And some ventilators will call this mode spontaneous, and some will call it CPAP or pressure support, or CPAP/pressure support. And there's differences in all these things, which we're going to go over. But CPAP is pretty much just a positive pressure at the airway as the patient breathes in and out. So the pressure is the same during inspiration as expiration. We just increase the pressure so the patient breathes spontaneously. And hopefully this may prevent some atelectasis. You know, we have patients in the intensive care unit, they're sick, they're on a ventilator, they're prone to atelectasis. So with that little bit of positive pressure kind of stinting the lung open while they breathe is mostly the reason why we use that. Pressure support is a positive pressure that is only on inspiration. So when the patient starts to breathe in, the machine increases the pressure at the airway, and that allows the patient to breathe in a faster flow, get a bigger volume without having to work harder to get that. So those are the kind of the spontaneous modes. So I skipped over IMV here because we talked about that a little bit. The IMV, intermittent mandatory ventilation. The patient's breathing spontaneously, and intermittently the ventilator gives the patient a breath. Another way to say that is that the patient has a set rate on his ventilator and he's getting that many breaths and he can breathe spontaneously in between. Those are the same thing. And today all of our ventilators that have SIMV have the S in front of the IMV, SIMV. They don't really do much of this IMV anymore. Now, when the patient is breathing in IMV, he's getting some mandatory breaths and some spontaneous breaths. The mandatory breaths can be volume controlled if we choose volume controlled breaths or pressure controlled breaths. So this is pretty much our three modes. The ventilator's doing all the breathing, the patient's doing all the breathing, or this IMV, SIMV, is where some of the breaths are from the ventilator and some are from the patient. And that's our three modes of ventilation. Volume control is on a knob, a button you select on your ventilator, and it's not a mode. A lot of people call it the volume control mode, but the volume control is the breath type. The breath type is volume, or we can set the patient in pressure control ventilation. So the breath type is pressure control. And over here on the CSV, CPAP is the way the breaths are, the spontaneous breaths with the patient breathing in it with a CPAP, continuous positive airway pressure. Pressure support is not a mode, although you'll have ventilators that'll have mode and you select pressure support. And a lot of people will tell you, yeah, he's in the pressure support mode. Well, I don't go around correcting people when they say that. It's not useful, and it just you can irritate a lot of people by correcting everybody on all this. I know what they mean when they say he's in a pressure support mode. He's in a spontaneous breathing mode. So some of your ventilators, when you're selecting mode, will say CMV. Some will say assist control. It means the same thing. SIMV is what you're going to see on your ventilator. You won't see IMV anymore. CSV is not something you'll see on a ventilator. This is a textbook term, continuously spontaneous ventilation. The ventilator will say something like spontaneous or CPAP or pressure support or some other things that they have, as we'll go over as we go through this. So let's start with, I think it helps if you do some scenarios and you see how we use this on a patient, and then it starts to make a little more sense. Let's say we are working in an intensive care unit. It's a surgical intensive care unit, and they have patients come out of surgery that have had open heart surgery and appendix taken out, or trauma patients that need surgery, whatever. But the ward secretary calls you and says that they called from the operating room and you're going to have a heart come out in at 2 o'clock this afternoon. And what they want is for me to set the ventilator up to be ready for the patient when they bring him out of the operating room. When you say a heart, it's not just the heart, they bring the whole patient. So I got the ventilator in the room, and the anesthesiologist brings the patient in. He's bagging the patient, and he says, let's give him a 500 milliliter tidal volume and give him 12 breaths per minute. Now we're going to use this mode CMV, all mandatory ventilation. So the patient is still paralyzed, not breathing. He's in la-la land. So on the ventilator is giving him 12 breaths every minute, and his tidal volume is 500. And so you know about minute ventilation, right? The minute ventilation is the tidal volume times the respiratory rate. That's how much air the patient is breathing per minute. This is what regulates the CO2. If our patient, let's say a half hour later, we get a blood gas on this patient, and the blood gas shows that his CO2 is 50. That's above normal, right? We would rather that be 40. Well, we can adjust that by making a change on our ventilator, because CO2 is regulated by the minute ventilation. So to blow off more CO2, we increase the minute ventilation. So we're going to increase the minute ventilation to 7.5 liters. Now this is just a way it's often done. They look at the blood gas and say, well, just go up from a rate of 12 to a rate of 15. Well, you could make that minute ventilation be 7.5 liters by turning up the tidal volume or by turning up the respiratory rate. Either one would make the minute ventilation go up. Now, we have ways of determining the tidal volume that the patient should have. Big people need big breaths, little people need little breaths. So we calculate the tidal volume that our patient would need. And when we need to adjust for a higher or lower minute ventilation, we're going to use the rate knob. So we're going to increase the respiratory rate. And that's what we did here. We went from 500 times 12, that's 6 liters a minute, to 500 times 15, which is 7.5 liters per minute. And we do a blood gas and his CO2 is 40. We nailed it. We're good. Well, now the things to remember about this SimV is that the tidal volume is guaranteed. So that tidal volume is going to be pushed into that patient by the ventilator. And the ventilator is going to have to generate a certain amount of pressure to put that volume in. How much pressure does it take to deliver a 500 tidal volume into somebody's lungs? Give up? Well, it depends on the patient. Some patients are harder to ventilate than other patients. So we set a volume, and that's guaranteed, but the airway pressure is a variable. We can tell what that airway pressure is because our ventilator will report that to us. We look and we'll see what the pressure is, okay? And say on this patient, its airway pressure is going to 20. Okay, and so that's considered a safe pressure. We like to keep that pressure less than 30. So everything's looking pretty good on this patient here. He's got a good blood gas. Pressure's not too high. And 1 hour later, this patient's sedation starts to wear off. He starts to wake up. And now when he's awake, his body's going to be producing more CO2 because it's burning more oxygen because he's moving. In the operating room, he was paralyzed, and so his muscles weren't really using very much oxygen and making very much CO2. But now he's breathing, and that takes energy, and so he burns oxygen and makes more CO2. Also, he's perhaps worried. He just came out of the operating room. He had open heart surgery. He's seen all the TV shows. Sometimes people don't survive. And so he's worried about his family. And also, he's probably feeling some pain because the nurse is starting to take away all these drugs. And so all of those things make you produce more CO2. So now this 15 breaths per minute may not be doing it for him. So he starts to breathe more than 15 breaths per minute. Now he's breathing 20 breaths per minute. Now what is his minute ventilation? Any guesses? He's breathing 20 breaths per minute with a 500 tidal volume. 500 times 20 would be 10 liters. He's breathing 10 liters a minute is his minute ventilation now. And because remember that tidal volume is guaranteed. Also, the patient may have developed some atelectasis, or the nurse may have a lot of fluid going in the patient. He becomes fluid overloaded. He may need to be suctioned. He could have bronchoconstrictions, or lots of things that would make it more difficult for the ventilator to put in this 500 tidal volume. But the 500 tidal volume is guaranteed. What's not guaranteed is the pressure at the airway. So now we see here that the pressure was 20 to deliver that 500. Now it's 25. So something has made it so that it takes more pressure to put that air in the patient. This is very often one of these two forces that oppose inflation of the lung. One is the resistance to airflow through the airways. If he has a lot of secretions, needs to be suctioning. Those increased secretions cause a narrowing of the airways, and so the airway resistance is increased. If he developed atelectasis, or if he's fluid overloaded, or one of those kind of problems, his lungs are going to be more difficult to distend. So, in other words, his compliance is decreased. There's an increase in elastance. So the two forces that oppose inflation of the lung, airway resistance or the lung compliance, one of those is probably the problem. So we just figure it out. And one thing we might want to do is suction the patient. If the pressure comes back down to 20, well, that's what it was. We listen to his lungs. We hear wheezing. He might need some bronchodilators. If it's the patient being fluid overloaded, or some atelectasis, and it could even be the position that the patient is in the bed. Anyway, there's been some change here. The thing that I want to impress upon you here is when you're in volume control, the volume is guaranteed, but the pressure is a variable. So let's say we do the same scenario. The patient comes out, the anesthesiologist is bagging, comes in the room, and he says, well, let's give him a 500 tidal volume and 12 breaths per minute, just the same as our last scenario. 500 tidal volume, 12 breaths per minute. But the anesthesiologist wants you to use pressure-controlled breaths. So I'm not going to set a tidal volume. Well, how am I going to get 500? He wants 500 tidal volume. How am I going to do that? Well, I'm going to have to do a little trial and error. I'm going to set a pressure and see how much volume I get for that pressure. And it's really hard to tell what that might be. But so I'm going to start with a nice safe pressure, 15 centimeters of water pressure. So now, since I'm in pressure control ventilation, the ventilator is going to go to 15 centimeters of water pressure and hold that 15 centimeters of water pressure for a certain inspiratory time that I set. And say I set the inspiratory time for 1 second. So while there's 15 centimeters of water pressure at the patient's airway, for 1 second, there's going to be air delivered into his lungs. And so how do I know if he got 500? Well, I have to wait till the patient exhales and I see how much volume he exhaled. And in this scenario here, we got the pressure set at 15 and his exhaled tidal volume is 400. So now his minute ventilation is 12 times 400 would be 4.8 liters. Well, the doctor ordered 500, so what am I going to do? How can I get 500? I'm only getting 400. Well, I just turn up the pressure. So I turn up the pressure from 15 up to 20. And now I look at the ventilator, and the ventilator is reporting 500 tidal volume. So I'm there. I've followed the doctor's orders. So now he's getting 12 breaths per minute times 500, 6 liters a minute. Remember our other patient who was getting 12 breaths per minute, 500, 6 liters a minute, but he was in volume control, not pressure control. So which one is better? Well, they're both the same. If the minute ventilation is 6 liters a minute, it doesn't matter whether we're using pressure or volume to deliver that breath. The minute ventilation is going to be 6 liters per minute. Now, remember, what would happen to this patient if he developed atelectasis or secretions in his airway, making the ventilator harder to ventilate him? Would that pressure go up? No, because we preset that pressure. That's the pressure every breath. What's going to happen is his tidal volume is the variable. So we come back later and find that his tidal volume has gone down for the same pressure. And so we may have to adjust the pressure up a little more, or we might just suction the patient, or figure out, what's caused the pressure to go up, and deal with the problem. Okay, again, 1 hour later, sedation's wearing off, the patient wakes up, now he's breathing 20 breaths per minute, and his tidal volume is 400. So now he's not getting the tidal volume that the doctor ordered. And now that he's breathing 20 breaths per minute, he's going to get 20 breaths times that 400. And so first of all, I'm going to try to figure out why the pressure has gone up and see if I can fix that. Or I might have to turn his pressure up a little bit more to give him the tidal volume that the doctor has ordered. So here's the thing to remember about the difference between volume control and pressure control. In volume control, the tidal volume is preset, guaranteed. The pressure is variable. In pressure control, the pressure is preset and the volume is variable. Now, you'll have some respiratory therapists and doctors tell you, well, I prefer pressure control. And others say, well, I prefer volume control. Which one is better? Well, if you got the same tidal volume and the same respiratory rate, the blood gases in the patient will be no different. And they have not really found through studies any difference in these two ways of ventilating the patient, either targeting the pressure or targeting the volume. What will be best for the patient is doing what you feel most comfortable doing, which is usually what you've been doing all along, because you'll find some hospitals all their ventilators are in pressure control. So the RTs working for years and years just using pressure control are not as familiar with the volume control, although any respiratory therapist should be able to use volume control or pressure control, and both just as safe and both just as effective for the patient. Now let's look at SIMV, synchronous intermittent mechanical ventilation, or mandatory ventilation. The patient is breathing spontaneously, but intermittently there is a mandatory breath delivered. And with SIMV, we can have those mandatory breaths be volume or pressure targeted. We can use either one, whatever we're most comfortable with, or whatever the doctor orders if they choose to order that. Now, the spontaneous breaths can be pressure supported, and pressure supported means that during the spontaneous breath, the pressure at his airway, the ventilator puts out flow to make the pressure at his airway be higher, so he will get a bigger tidal volume because of that pressure. And the higher you set the pressure support pressure, the bigger the spontaneous tidal volume. But it's considered spontaneous tidal volume even though there is pressure there making him get a little bit bigger breath, because the patient is initiating the breath. He's determined the timing of the breath, how long inspiration is, and how big a tidal volume he gets. That's being controlled by the patient. So even though there is pressure support, these breaths are considered to be spontaneous breaths. And I notice here somebody misspelled breaths. That says breathe, doesn't it? So if we have a patient who is in the SIMV mode and his tidal volume is 500 and he's getting the set frequency on the ventilator, the SIMV rate is often called, is 10 breaths per minute. Now he's allowed to breathe spontaneously, and we look at our machine and the machine is reporting that the patient is breathing 16 breaths per minute. Well, we know that 10 of those breaths are going to deliver a 500 tidal volume, and by watching the exhale tidal volume we can tell his spontaneous breaths are smaller, and they most often are going to be smaller, the spontaneous breaths. And so we see on our ventilator that this patient is breathing spontaneously 300 milliliter tidal volume. So since his total respiratory rate is 16, 10 are coming from the machine. That means 6 must be coming from the patient. So now how would you calculate his total minute ventilation? 10 times 500 would be 5 liters, but that's not his minute ventilation because he's adding to that 6 times 300. So 10 mandatory breaths, 500 tidal volume, 500 times 10 is 5 liters. And we add to that 6 spontaneous breaths, 300 milliliter tidal volume would be 300 times 6, 1.8 liters. We had 5 liters and 1.8 liters. His total minute ventilation is 6.8 liters. Now, they gave us SimV a long time ago, telling us that this is the best way to wean your patient off the ventilator. Because remember, back in the olden days, we had pretty much had 2 modes, on and off. The patient's on the ventilator or he's not on the ventilator. And so we have a patient that has been on the ventilator for a while, and his x-ray's starting to improve, and he looks better. And so we take him off the ventilator and see if he can breathe, right? And so what if he doesn't? What if you always see is rapid shallow breathing and the patient getting diaphoretic and the CO2 goes up? Well, we just got to put him back on the ventilator. Well, so that made it kind of difficult getting patients off the ventilator. So the ventilator salesman told us that this is how you wean the patient off the ventilator. You gradually withdraw ventilatory support. So for instance, you would have the patient on the ventilator, put him in SimV, and have the ventilator give him 12 breaths per minute. So he breathes a little bit of spontaneous breaths along with those 12 breaths from the machine. And then you decrease that respiratory rate down to 10 breaths per minute. Now the ventilator is giving him less, so the patient's going to have to breathe more. And so later or the next day, you turn his respiratory rate down to 8 breaths per minute. And now the ventilator's doing less work, the patient's having to do more work. You turn it down to 6 breaths per minute. And that sounded perfectly reasonable. You're returning the work of breathing from the ventilator back to the patient in a staged manner. And so we did that all over the world. Everywhere where they used ventilators, patients were weaned off the ventilator using SimV. It made a lot of sense. Just thinking about it, that makes sense. However, when they started studying this back in the 1990s, some researchers started doing some research and found that that was the worst way to wean a patient off the ventilator, even though it sounded reasonable. But what they found was that when they used SimV to wean patients off the ventilator, they were on the ventilator longer, and more of them became ventilator dependent. So now we don't really use SimV for weaning most places. So there's still some doctors who are living in the past that might want to use SimV to wean the patient, but it's not recommended, and that's evidence-based. Okay, let's talk a little bit more about this CSV, continuously spontaneous ventilation. So if we're in CSV, the patient breathes. If he doesn't breathe, he doesn't get anything. There's no breaths coming from the machine because the respiratory rate is 0 from the machine. So it's all spontaneous breathing. Some ventilators, when you select mode, it'll say spontaneous. And some ventilators, you'll have a place to set CPAP or pressure support. All of those are spontaneous breath types. Pressure support, remember, is a breath type. So would we intubate a patient and just set the ventilator on spontaneous when he doesn't get anything from the ventilator? Probably not. If he needed to be on a ventilator, he probably needs some help from the ventilator doing some of the work or all of the work of breathing. If he can breathe spontaneously with no help from the ventilator, he probably doesn't need to be intubated. So the fact is, we don't put a patient on the ventilator and just put him in spontaneously, usually. For one thing, there is an imposed work of breathing through the endotracheal tube. And so we need to give him some pressure support just to help overcome that resistance. We do use spontaneous on the ventilator occasionally, or CPAP, where the patient is not getting anything from the machine, he just breathing spontaneously. We use that pretty much only to do a spontaneous breathing trial. Say our patient has been on the ventilator for a while, he looks good, his blood gas is good, x-rays cleared up. Well, rather than extubate him and see if he can breathe, we like to see that he can breathe before we extubate him. So we would do what we call a spontaneous breathing trial, SBT. And so we put him in in a spontaneous breathing mode, either CPAP or a low level of pressure support, just enough to overcome the resistance of breathing through the tube, and watch the patient for about a half an hour. Because if patients fail to be able to breathe, usually happens right away. So doing it longer than a half hour or so is really not necessary. But also for pressure support, we may have a patient who's on the ventilator and we're not going to extubate him for whatever reason, but we put him in pressure support so he's more in control of his breathing. So he should be more comfortable breathing with pressure support than in a mode where the machine is mandating breaths. So if we put the patient in pressure support and say give him 8 centimeters of pressure support, and he's breathing fast and shallow, well, he needs more pressure support, so we might turn his pressure support up to 10 or 12. But if it takes like 16, 18, 20 of pressure support, the patient probably needs some kind of control ventilation where we deliver a tidal volume or deliver an inspiratory pressure and pressure control. So pressure support is a way to have the work of breathing shared between the patient and the ventilator. As we turn up the pressure support, we're turning up machine work of breathing. And if we're turning up machine work of breathing, then we're turning down, hopefully, patient work of breathing. So as we increase the pressure support, the patient gets bigger tidal volume, or he gets the same tidal volume, but with less work. So pressure support, we should think of that as machine work of breathing. Now, if we put the patient just in CPAP, the pressure is the same during inspiration and expiration, so it doesn't help the patient take in a bigger breath. So in CPAP, the work of breathing is 100% patient work of breathing. And if we just put him on the ventilator with nothing, no CPAP, no pressure support, the work of breathing would be 100% patient work of breathing. Pressure support, the work of breathing is shared. So CPAP, you learned about CPAP for patients with obstructive sleep apnea. And they put a little mask over their nose, and it increases the pressure continuously in their upper airway so that they don't have this airway collapse when they fall asleep at night and snore and their airway closes off. So this is not what we're using it for with our ventilator. Because one thing, the patient is intubated with our ventilator probably. And if he's intubated, he's not going to have obstructive sleep apnea. So we pretty much use CPAP on our ventilator for performing a spontaneous breathing trial. And the important thing to remember here is that all the work of breathing is done by the patient. This does not help the patient to breathe. If he has high airway resistance or low compliance and he has to work hard to breathe, the CPAP probably isn't going to be of much help for that. He needs either pressure support or be put into some control mode of ventilation. The pressure support is, as I said, the work of breathing is shared between the patient and the ventilator. When we turn up the pressure support, let's say we got a patient, we put him in pressure support and he's breathing fast and shallow, increases pressure support. He should get bigger breaths. If he gets bigger breaths, he doesn't have to breathe as many breaths per minute. So that's what we're watching for when we put a patient in pressure support. We want to make him comfortable. No matter what mode or breath type we're using for our patient on the ventilator, one of our goals should be to make the patient comfortable. Having the patient have an increase in work of breathing is not of benefit to the patient. I know in the past sometimes doctors would want to work the patient out. So we'd do these things called wind sprints. We'd take them off the ventilator and they'd chug away for a little while as long as they had tolerated it. And they thought that they were building up the patient's respiratory muscles, which turned out not to be true at all. What we were doing was we were fatiguing their respiratory muscles. And I know you've heard about and seen and played with our BiPAP machines, NIV ventilators, like the V60 is a common one we're using today. There's also one called the Trilogy, and there's some other ones. But pressure support is the same thing as the IPAP. on our non-invasive ventilators. So you've already had some experience with pressure support. It was just called IPAP. Okay, let's see what we figured out here. We have here's another little scenario, a little test for you. Got a patient in the ICU, ventilated. He's in SIMV. The respiratory rate set on the ventilator is 8 breaths per minute. Tidal volume is 400. The total respiratory rate is 20, and the patient's spontaneous tidal volume is 300. So this is the same thing, the problem we just worked out with our other SIMV patient. He's getting 8 breaths that are 400, so that would be 3.2 liters. And he is breathing a total of 20 breaths, so he must be breathing 12 breaths spontaneously. So 8 breaths per minute times 400 is 3.2, and we add to that 12 breaths per minute, his spontaneous breaths. Here's his mandatory breaths, and here's his spontaneous breaths. So we add those two together, and we get 6.8 liters. This patient's minute ventilation is 6.8 liters. Okay, now let's do it a little more complicated, more realistic kind of a scenario here, where a respiratory therapist gets called to the emergency department, and they want you to draw a blood gas on a COPD patient who's 70 years old, and he's getting his oxygen via non-rebreather, and he's in the emergency room. And you get the blood gas back, and you see his PaO2 is 89, his PaCO2 is 82, and his pH is 726. So what kind of respiratory failure is this? Well, he's breathing with a non-rebreather, and his PaO2 is only 89, so he's got some oxygenation issues. And his CO2 of 82 with a pH of 726. If that was his normal CO2, his pH would be 740. And when we see a CO2 of 82 and the pH is only 7.26, it should be a lot lower than that. With a CO2 of 82, his CO2 should be 7.1 or something like that. So we have a patient who has acute on chronic hypercapnic respiratory failure. So what do you think about this patient? Do you think you should intubate him? Any ideas? Would you intubate this patient? Well, you suggest to the doctor NIV. And the doctor says, well, BiPAP might help with ventilation, but this patient also has an oxygenation problem, and he does. He points out that the patient's PaO2 is only 89 on a 100% non-rebreather mask. And you remind the doctor that a non-rebreather mask does not deliver 100% O2. Now you're going to find that a lot in the hospital. A nurse will draw blood gas in the ICU and send it off to the blood gas lab, and on the blood gas slip on the FiO2 she'll write 100% non-rebreather. Well, it's not 100%. You've learned that. It's probably more in the range of 70%. And so you point that out to the doctor, and because we're always helping to educate the doctors with stuff about mechanical ventilation. They need some reminding. Furthermore, the NIV may help the patient to eliminate more alveolar CO2. So, with a bigger tidal volume, he's going to get more alveolar air, and so there'll be less CO2 in the alveoli, right? Because there's only room for so much CO2 and so much oxygen, and if you increase the amount of oxygen, you decrease the amount of CO2. And the other way around, if you increase the amount of oxygen, you decrease the amount of CO2. So the but physician doesn't agree. And you're going to get a lot of this. Physician disagrees. Not only on your licensure exam, you'll pick the best answer, and it'll say physician disagrees, which on that test, it doesn't necessarily mean you picked the wrong answer, or maybe there is a better answer. So anyway, the doctor intubates the patient, and he puts in a size 8.0 ET tube and asks you what ventilator settings you recommend. Okay, the patient is 5'6", and he weighs 175 pounds. So the patient was paralyzed for intubation, so it would be appropriate to set him in SimV, resist control, whatever you want to call it, and we could use volume control or pressure control, either one. And now we're probably going to start him on 100% because he does have a pretty serious oxygenation problem. We don't know how much he needs, so we're going to start him out at 100%. We're going to watch the pulse oximeter, and we're going to turn that down sooner rather than later. We don't want to leave him on 100%. And what about a respiratory rate? Now, the initial settings on the ventilator, remember, is 12 to 18 breaths per minute. So we want 12, or we want more like 18. Well, remember, this guy has COPD. So what does that mean about his expiratory time? How much time does he need to exhale? Longer than most patients. And so we're going to probably set our respiratory rate closer to 12 than to 18. We want to give him as much time to exhale as we can. And let's say we know we want to give him a tidal volume of between 6 and 8 mLs per kilogram. So we just pick the middle one there. We pick 7 mLs per kilogram. So what tidal volume will we set? Our ventilator is going to want us to to deliver the tidal volume in mLs, not mLs per kilogram. So we're going to have to do a little math and figure out this guy's ideal body weight. 7 mLs per kilogram. But we don't know what his ideal body weight is. We're going to have to do some math, right? Remember, he's 5'6" and he weighs 175 pounds. So we're not going to use 175 pounds. And when you take exams, this is a kind of a trick. If you tell him how much the patient actually weighs, we don't give him a tidal volume based on how much he weighs. We base our tidal volume on how much he should weigh, or his predicted body weight. And so we have to base that up on the patient's gender and height. So he's 5'6". What tidal volume would this patient get if we give him 7 mLs per kilogram ideal body weight? Well, remember earlier in a previous presentation, we talked about ideal body weight. Remember, a male patient 5 feet tall has ideal body weight of 50 kilograms. A female 5 feet tall has an ideal body weight of 45. Actually, it's 45.5, but mostly we just use 45. And then we're going to add 2.3 kilograms for every additional inch. The patient is 5'6", so 50 kilograms, plus 6 times 2.3 kilograms, because for every inch over we want to add 2.3. And so 50, 6 times 2.3 would be 13.8. So 50 plus 13.8, his ideal body weight is 63.8 kilograms. It's his ideal body weight. So we want 7 mLs per kilogram, so we just multiply 7 times 63.8. And we, in reality, we might just use 64, but it wouldn't really make much difference there. But here, 7 mLs per kilogram times 63.8 equals 446.6. Well, we're not going to set 446.6 on our ventilator. We're just going to set 450. That's, really, really close. It's just a small syringe full of air difference. So that's where we would have our patient set for the tidal volume. That's how we calculate it. Now, you should always be thinking of tidal volume in terms of mLs per kilogram. Sometimes the doctor will order a tidal volume of 500, and you need to calculate mLs per kilogram. Make sure that's not too big a breath or too small a breath. If the doctor orders 500 and that turns out to be 10 mLs per kilogram, we don't want that. We need to approach that doctor and explain that that's too big of a tidal volume. We need to give him a smaller tidal volume. That's 10 mLs per kilogram. We've done a lot of research here lately, and we know that when we give too big a tidal volume to our patients, it tends to cause lung injury, and we sure don't want that. We want to intubate a patient and have him get better, not get worse. So that's about it for modes for now. There's a lot more to it. They have come up with new ways of ventilating patients that we'll go over later. We have modes that are called interactive modes, and just different ways that we can ventilate patients. And then there's a lot to the non-invasive ventilation and other modes and breath types that can be done on that. But we'll wait till later to do that. Before we move on to that, I want to talk, and it'll be on our next presentation, how we monitor the ventilator, make sure the ventilator is doing what it's supposed to be doing, and see how the settings are and how we document all of those kind of things, which is something the respiratory therapist does usually about every 4 hours. They go around to all their ventilators and do a very thorough check on their ventilator. And also in the next segment, Introduction to Mechanical Ventilation Part 3, we're going to talk about all the alarms on the ventilator and what those alarms mean, how to respond to them, and how to set them and where they should be set. The alarms are there to protect the patient from anything that might happen to the ventilator circuit, the humidifier, any problem that may occur inside the patient, like say a pneumothorax, going to set off alarms. So we're going to talk all about that. So I'll see you next time. I'll have that part 3 posted on YouTube in probably a couple of days here before the weekend is over. Okay? Bye-bye.